Wonderful. Kids have finished
Good.
school.
I haven't talked to Antonio for a while. Is he okay?
The last time I spoke to him, he was doing great. I'm gonna actually call him later today,
Yeah, I do
and
too.
say how he's doing.
Well, I texted him for his birthday. He sounds like he's
Oh shit! Tell me when is his birthday?
it was what? Was it last
It was
week?
on the 17th.
Yeah.
Now you missed it by a couple of weeks.
Yeah.
17th of what? June?
June, yeah.
For some reason it's on my calendar. So I always,
Well, that's why I'm putting it on now.
I send him a cake.
So maybe we should start, Jeff. It's just past 6:30. We've got a nice group of people, over 60 people who joined. So good morning or good evening, everybody, and to all the fellows. Thank you for joining us today. We're really lucky to have a good friend and mentor, Jeff Moses, who's joining us and talking about left main disease, why I do it, how I do it. Jeff, when we thought about left main, I couldn't think of anybody else, that I wanted to ask to talk about left main other than you, because I knew you would take us through the data, plus give us some clinical tips. So the way we do this, Jeff, you'll see in one of the videos, Aisha, who's one of the fellows. We always have one fellow join us. And Aisha will, in the end, she'll actually, because it's for the fellows, she'll moderate the questions and ask you questions, if that's okay.
Oh yeah. And
Right.
if something's popping in the middle of my talk, just jump in. Okay.
Awesome. Great.
Well, it's a pleasure to be here. First to speak to all the fellows. I guess I don't know if they're incoming fellows yet, but welcome to the world of interventional cardiology. It's as fraught as all the other worlds that we're living in these days. And Azim, thanks for inviting me. It's a pleasure to support you. I've known Azim since his fellowship, and watching him grow into really one of the outstanding interventionalists, both thought leaders and technical proficiency, is just been a pleasure to watch. And of course, Eberhard Grube is here too, who can jump in and correct me in anything I'm saying wrong. Okay. So I want to drill down on how we got to where we are in terms of these current recommendations, because I think it's very important for all of us to understand what the data actually are. There's been a lot of noise around this, and the facts, I think, are pretty straight and pretty compelling. But the U.S. guidelines, we'll get, not the AUC, but the guidelines really haven't been updated in the U.S. for quite a while. And really, they focus on CABG as being the preferred treatment. And as you can see, it's nothing better than a 2A for PCI. And also there are a lot of caveats in the U.S. Guidelines about the actual surgical risk, and a non-high risk patient really doesn't even fall into these categories. The European guidelines, which are much more updated and I think less politically weighted towards surgical prejudice, to be honest with you. Of course, CABG is a straight green, but we did make headway into the low syntax score, and in intermediate it's 2A with an A class. And I'll talk a little bit about that, because when you see the data, there's no reason for this to be yellow and this to be green, but it was just done as a lot of legislation of political compromise. But let's go back and step back and say how this all evolved. This is the syntax trial. And the syntax trial, remember, was a global trial of left main and 3 vessel disease, but it was predetermined to do subset analysis on the left main group. And what they did that was clever and I think groundbreaking is they set up a scoring system based on anatomic complexity, which also fortunately correlates with extent of ischemia on on sort of an angiographic basis. And they analyzed the data not just by the anatomic subsets, but also the syntax score, which was very important, because as Patrick Serois would say years ago, there's 3 vessel disease and then there's 3 vessel disease, and and you can know that. So, but also remember, all this is hypothesis generating because there were no differences. It did not meet non-inferiority in the overall trial, but nonetheless, it gave a lot of guidance for the guidelines for many, many years. And what you can see here in the low syntax score group, and remember, left main contributes a lot to this 0 to 22. So what you're talking about, the residual disease, is actually relatively simple. And what you saw here is there was no difference in death. Strokes were higher in Cabbage. MIs was a slight difference, but if you look at the overall death MI and CVA, it was actually pretty much a dead heat in the low group. When you moved up to the more intermediate group, again, this is sort of a fluke. You have a doubling the Cabbage number of mortalities here, but this is just the vagaries of small numbers. But again, if you look at death, CVA, or MI, again, because of this disproportionate mortality rate, it looked higher in Cabbage. But the point is, the message here is there's no striking difference. And when you look at the cumulative event rate of MACE, it was pretty much identical. And where the break point came, of course, was when you looked at the high syntax score, the greater than 33, and then you saw the rates, the overall MACE rate almost double with the PCI group. And while the mortality wasn't strikingly different, as you can see, it was really driven by a tripling of the revascularization rate and a doubling of the MI rate. And that was sort of the foundational data actually for the guidelines for quite a while. But when you step back from these data and look at it in a more nuanced fashion, and when you take the syntax 2 score, which also takes into account not just the anatomic, but of course, many clinical factors, when you really looked at the confidence intervals and in terms of what was preferred, if you really looked at it, it was about 80% of all the left mains that were in the syntax trial actually were within the confidence intervals, 95%, and could have gone either way. And this gave us a hint that, surgery and PCI may have more of an equipoise in certain subsets, clinical and anatomic, than we thought previously. And I think this is also very important, especially when we get to the more detailed analysis of some of the long-term follow-up and mortality data. When you looked at the syntaxis, which is the extended mortality outcome from syntax out to 10 years, what you see is there's really virtually no difference in mortality. It's spot on. And keep in mind that, as I like to say, that, and no offense to Eberhard and the like, but the Taxus stent was one of the most dangerous stents ever put out commercially. It had a very high thrombosis rate, a 10% thrombosis rate over 3 to 5 years, and a very high, relatively late loss. So this is where we stood for quite a while, and it was with first generation drug-eluting stents. These data, remember, are subsets of subsets, and they were just hypothesis generating. And also, over the course of time from syntax on, besides the stent improvements, we had many improvements in our technique, more image guidance, real ischemia guidance with localized ischemia with FFR and RFR, a much greater ability to really tackle CTOs and yield complete revascularization. So that was what really drove the 2 main trials, the Excel and the Noble trial. And as you can see here, there were some differences, but the key is these were not severely complex patients. The caveat of the 33 and above and the outcomes from the syntax trial really put a cap on it when we designed Excel and the Noble. And I'll show you the follow-up. We have about 5-year follow-up, and we did recommend, IVUS guidance and FFR guidance, and really incorporating contemporary techniques into these trials. The Excel was a larger trial. The Noble was 1,200. But as you can see, it was a pretty similar group of patients with a syntax score in the mid-20s. The diabetic subset, of course, Noble being more European, was only 15%. The Excel had a heavy US space, so it was about 30%. But there was very high use of IVUS. A lot of distal left main lesions, again, very important here. And the surgery was actually quite good, with Lima almost universally used, and in an arterial conduits only actually in about a quarter of the patients in the Excel study. Now, an important aspect of the Excel was the registry. And what happened was, for the first 1,000 patients that were rejected, you had a concomitant registry while you were screening for the trial. And a lot of patients fell out. Those who fell out, a lot of them went to CABG, about a third of them went to PCI. But I think, and these are the reasons why they fell out, but I think the important aspect here is during this concomitant time, 62% of the patients coming through all these labs for screening were actually eligible for PCI, which was, of course, a requisite for Excel. And I think that's important when we look at the contemporary usage of left main PCI, excuse me, because it's a very high percentage of patients who come through the cath lab actually fall into the Excel group. It's not a rarefied group. Now, here's the top line data, the 5-year data that were in the New England Journal last year. And as you can see here, you have a non-significant difference in the primary endpoint of death, stroke, or MI. But keep in mind, we'll drill down on this more, is that we have an early advantage for CABG, and this was because we did talk about large peri-procedural MIs were included in the Excel trial, which were greater, of course, in the CABG group than the PCI. But as you can see, somewhere around 3 years, the curves do start to cross. And we're going to drill down on that because that's a source, I think, of important considerations for patient care, and also sparked a bit of controversy. So really, when you think about this, you got to think about the hazard ratio in 3 segments. Number one, obviously PCI gives you an early advantage, especially when you're counting large peri-procedural MI. For the first year after, it's really the MACE rate, this death, stroke, or MI rate are virtually similar. But as you can see here, the curves do separate significantly in favor from 1 year out to 5 years in favor of bypass. And when you break these down, you can see again that the overall death rate here again is similar, as I showed on the Kaplan-Meier curves. But what you see here is a difference in death, and this is an important number because this has been emphasized by a lot of individuals. You can see there's a 3.1% difference, a 1.38 hazard ratio. But when you drill down on it, you look at a bulk of that 3% is actually from non-cardiovascular causes, 2/3 of it. And cardiovascular is maybe a 1% difference at 5 years, and the definite non-cardiovascular death is actually virtually similar. Strokes, of course, do favor numerically PCI. And again, myocardial infarction, when you look past the peri-procedural period, it's doubled with the CABG, as we noted, but again, late, the trend is in the opposite direction, and you see a doubling of the non-peri-procedural MI after one year. And I think that's important. And again, we just breaking down this difference here, as you can see, it was just this is a play of chance of infections, malignancy, these non-cardiovascular. There's nothing you can impute here to this mortality that would be mistaken for cardiovascular death, altogether. And again, another aspect of it, we're used to looking at, risk ratios with revascularization in these studies. And I think it's more important actually to look at the absolute numbers, because when you look at all revascularization, comparing PCI and CABG at 5 years, there's only a 7%, there's only a 7% difference. So it's really like, less than 1 in 10 difference in terms of the need for revascularization. CABG doesn't make you immune. 10% got revascularized, 9% of that PCI. In the PCI group, it was 14%, and 4.3% went to CABG. But this is another important thing, because there's a lot of notions, oh, doctor, am I just delaying my bypass? Well, here's 5-year data, and there's only less than a 5% chance that you're going to end up with a bypass if you're appropriately chosen for left main PCI. Interestingly, stent thrombosis was quite low, 1% definite, 0.7% probable, but this was offset by symptomatic graft occlusion in the CABG group. So when you look at the quote therapy failure, it's actually higher. It's actually higher in the CABG group. And that's also something that always frustrated me. When we go talk to our patients, you know, we say, well, our restenosis rate is X, your recurrence is coming to the hospital is Y. No offense to the surgeons, but it is rare that they'll tell, you know, there's a 20% chance that one of these grafts are going to be failed at 1 year, and there's a 6% chance that it'll actually have a clinical event. So I think we should really be talking apples to apples here. And this is just a subtle thing. This is looking for missing follow-up data to make complete in terms of all-cause death, stroke, and MI. And again, it really doesn't influence the outcomes at all. That's just a subtle point. Another important lesson, and this is becoming thematically very important, is that when you looked at the diabetic group, and remember that was 30% of the patients, you really had, you know, you have a slight increase in mortality, but the cardiovascular death rate is not very different here. Ironically, that non-cardiovascular death imbalance that we saw in the overall trial was particularly driven by the diabetic subgroup. So in reality, the cardiac mortality is not that different at 5 years. And when you look at the myocardial infarction rates, again, spontaneous, of course, is a little higher. But, you know, the heavily weighted prejudice against multi-vessel disease, PCI and diabetics in contemporary treatment does not seem to be all that profound. Now, looking at Noble, which again was spoken about as a quote negative trial, keep in mind it had a different endpoint from Excel. And we specifically excluded revascularization from Excel because we felt that that's just the cost of doing business. You accept that with PCI, that would be a difference. And what we really wanted to look at was the hard endpoints of mortality and myocardial infarction. So Noble did not meet the non-inferiority margin. Here's his 5-year follow-up again. That's predominantly driven by TVR. But when you looked again at all-cause mortality out to 5 years, it's actually looking pretty much like Excel. Again, MI was weighted with a growing benefit for CABG. And remember, in Noble, there was no systematic collection of data for peri-procedural, so you don't have that offset. And again, we see the revascularization difference. Interestingly, even though this is obviously a smaller subset of patients with diabetes in Noble, again, very, very tracking almost identical in terms of the overall MACE rate, interestingly, in the diabetics. Remember, the overall MACE rate overall was in favor of CABG. In the diabetics, you don't even see the MACE rate benefit. Other long-term data more recently is from Lee about the main compare study, looking at DES and left main. And what you can see here, and this was this is a matched data set from Korea. But again, when you look at the follow-up, when you look at all-cause mortality going out to 10 years, whether it's diabetic or non-diabetic, you really do not see any difference. So I think the diabetic issue, obviously you do see differences in TLR, 4% versus 26 in the diabetic group, but it's actually kind of different also in the non-diabetic group, 4% versus 20%, much higher than we're seeing in Excel and the like, and Noble. But having said that, the thematic consistency of lack of mortality benefit with contemporary PCI versus CABG for CABG is, I think, an important thing to keep in mind, and not just have a knee-jerk multi-vessel patients go to CABG. And I think it's important to emphasize that Excel and Noble it's very consistent in terms of the cardiovascular mortality, the myocardial infarction rates, And, and of course the differences in non-periprocedural MIs as well. A difference between the two, though, of course, is definite stent thrombosis. The Excel, remember, was exclusively designed stent. Noble had a mixture of stents with thicker struts and the like. So the thrombosis rate was a little higher. And paradoxically, stroke was actually higher in the PCI arm in the Noble. Again, we think that's play a chance. In Excel, it numerically the other way. And another consistent observation here, which I think is important. Now, remember, we did cap the syntax score at 33 in Excel. Noble actually had more of a general, non-complex entry criteria, not specifically the syntax score, but nonetheless, when you went to the core lab, there were a fair percentage of patients that actually had a high syntax score in Excel, I think about 20%. But these are not the 48s. These are the higher 30s. But nonetheless, you did not see a difference, excuse me, or any interaction between the syntax score and the outcome. So at least up to moderate elevations of the syntax score above 33, again, we did not see an interaction. You see that's true with Noble too. An important observation, of course, is there's no advantage to femoral versus radial. Interestingly, the bleeding rates were not that different, and the 3-year death and MI and stroke rate. So my message is, and that maybe runs counter to a lot of the contemporary thought processes, while I love radial for the simpler, more straightforward cases, but the complex cases sometimes with a lot of calcification, if you feel you need a larger guide or the like, or multiple wires, et cetera, you're not harming the patient by going femorally if you're good at it. So I think the new ground rules are, I think it comes to a mortality, there's not much of a difference between PCI and MI and diabetes and renal disease and in syntax score up to a point. But the point is, we don't paint by numbers now. You don't just check a box and say, oh, it's a diabetic, go to surgery. Oh, the syntax score is 33. Just, you have to have surgery. You have to really start thinking and understanding the data are much more nuanced, and you really got to think of the patient. Okay, so now I'm going to back off and talk about, we're used to firestorms in PCI. This was one that came up, which was quite controversial and made a lot of headlines. And I think it's important that we as interventionists really understand what this controversy is about and what's real and what's not real, because a lot of us operate off of sound bites and bottom line conclusions in certain papers. And, I was always taught when I read a paper, first read the methods and then read the data and form your own conclusions, then read the author's conclusions. And so today, I'm afraid in the Twitter era, it's quite the opposite. So what was the controversy? Well, one was the contention was periprocedural MI defined by the universal definition was not analyzed, okay, which is true, but this was a cover-up. Okay, now just to give you a little backup, there have been multiple definitions of periprocedural MI, and it's evolved. Here we have the third universal definition, which came along in 2012, and then the Sky consensus, which really emphasized high CKMBs and high troponins, because these correlated with actually outcomes in multiple analyses. But the point here is that, when we were forming the data sets for Excel, we didn't have these available. And actually, we derived our own, and we actually we did not want to do troponins because they were too sensitive. And we really looked for periprocedural MI, and we really just drew CKMBs. Now, the problem is, the universal definition doesn't have any real good criteria for CKMB. It just throws in there, well, any elevation, and it was there was no systematic ascertainment of troponins in Excel. So we couldn't really apply the universal definition very well. There was an attempt to do this with CKMB, and that analysis actually will be shown. But remember, it's a flawed analysis because it's not what you're thinking of in terms of the conventional troponin definition. So it's a mixed bag. But this was a priori. We were not going to look at the small MIs. And also remember, it was just one of 20 secondary endpoints. The definition we used, which is more like the Sky definition, really correlated with mortality on subsequent analyses. The universal definition does not. And we did, as I said, and also remember the Sky model actually modeled after Excel because we were using the same analyses and data sets to really point to peri-procedural events or biomarkers that actually correlated with outcomes. And interestingly, without getting into a whole diatribe about this, when you really analyze the data and look at the large peri-procedural MIs, you can almost always find something that happened during the intervention. So it's really an epiphenomenon, an actual complication. And another contention was we ignored the mortality difference. As I noted, the overall mortality was about 30% higher in the PCI group, as you pointed out. Now here we are with the results in the, right, this is the results in the abstract. And right after we talk about the top line results, the next thing is death from any cause occurred more frequently in the PCI group, 13 versus 9. Now, you can't put a secondary endpoint any higher in your abstract than right after the primary endpoint. So this was hardly ignored. And as you can see, we had paragraphs about this as well. But I think importantly, and this was an analysis that Yusuf Ahmed, one of our just departed SHIP fellows put together, which was published in February, looking at overall mortality with the longest follow-up in 5 studies, just to put this to bed. And what you can see here, when you look at all cause mortality of Noble, Syntax, Excel, pre-combat, and the smallest study by Boudreau, as you can see, the overall mortality is spot on. Cardiac mortality, if anything, leans towards DES, and and pre-combat just came out with its 10-year results, and we actually incorporated that in. This is submitted, but as you can see here, again, if anything, it just strengthens the fact that there's no difference in overall mortality. So I think the mortality difference is, overemphasized. And if anything, the weight of the data shows the mortality difference is marginal at best. Now, interestingly, Brophy just came out with from a Bayesian interpretation of these data, and this was sort of put out as indicating that, oh, well, maybe the frequentist analysis is flawed and there really is a difference, but without going into all the nuances of this analysis, the point is that when you looked at the Bayesian analysis, looking at the DES trials, the probability of more than a 1% difference is about 47%. This is in terms of mortality. So even in the worst case hypothesis, there's maybe a 50% chance that there's a 1% difference. And so that means that over 5 years, the difference for a patient would be, is it a 90% chance you're going to be alive, or does surgery take you all the way up to 91%? That's the order of magnitude we're talking about. And even that is less than certain. 47% isn't very high. And keep in mind the patient. These are 2 different procedures. We have PCI versus surgery. And if your chances are greater than 9 out of 10, either way that you're going to be alive, it's up to the patient to really decide which of these procedures does he or she want. And I think this for me was one of the better tables from Excel and analyses, because my complaint has always been, if I do a femoral procedure and end up with a pseudoaneurysm that goes to the OR, that's a complication. But if the surgeon has a take back with bleeding or an infection, that's part of the procedure. I felt that that was a bit of an imbalance. So here you can see there's just a lot, whether you're looking at bleeding, transfusion, arrhythmias, renal failure, wound infections. The point is that these are different procedures, and the morbidity and inconvenience and time out of work and pain inflicted on the patient is an important consideration when you're thinking about any imbalances that might be the case. So having gone through that, where are we today? Well, even though the guidelines in the US weren't updated, the appropriate use criteria were based on much of this data set. And as you can see, that the left main disease actually has, at least if not in the isolated is actually green, and it's not red. It is possibly appropriate, and I only look at the red in a lot of subsets of patients where it is an alternative for the patient. Okay, so it's not wrong to discuss this with patients. But the key here, when you're thinking about that and applying these data, you've got to think about how to get the same results as you got in Excel. And that, I think, is important to use contemporary DES. That's obvious. And I think they're all, in terms of thrombosis rates, restenosis rates, other clinical, other technical characteristics, for me, they're pretty much the same. But you really want to use imaging and hemodynamics. You don't want to FFR to avoid unnecessary stenting, but you also want to do complete ischemic revascularization. IVUS-guided left main is very important. You want to do optimal left main techniques and, of course, optimal pharmacotherapy. And we need to apply all these to really replicate those results. But interestingly, what's going on in the United States is that, remember, 60% of the patients who came through these centers during the early Excel period were qualified for Excel. If you look at the US, you have, here's from the NCDR, a little older data, but only 33,000 unprotected left mains done out of 3 million patients in the NCDR registry. The average operator did about less than 1 a year. Facilities did less than 4 a year, and half the hospitals and 84% of the operators did 1 a year. Now, why is this important? Well, look here. Let's look at the from the recent BISUS data, looking at operator volume of left main and relationships. And here we see the volumes across the BISUS data set. And what you can see here is a strong gradient effect with volume from in-hospital MACE, in-hospital mortality, and the higher volumes, 12-month mortality. So, and again, when you look at all these complications, as you can see, periprocedural MI, bleeding, et cetera, you can see volume leads to higher quality. And it did in the BISUS data have a breakpoint, interestingly, at about 15 left main procedures a year. And remember, the average operator in the US is doing less than 1. And I think this is very impressive when you look at survival over a year. It wasn't just a periprocedural issue, but this carried over out to 12 months in the higher volume patients. So practice makes perfect. Now, another aspect which we've got to keep in mind is the use of imaging. And the first use of imaging, forget the stenting, is it really left main? And IVUS is key in osteal lesions. And of course, while you're at it, if you're going to analyze the lesion, you might as well use it in all phases. But this is an old slide from Gary Mintz. And if you notice here, here's a left main lesion. And of course, there are surgical wires here. And here's the IVUS. There's nothing there. And I'm sure we've all had this experience where you've had patients you've cathed and you've said to them, well, the bad news is, well, all your grafts are closed. But the good news is we IVUS your left main, you didn't need the surgery to begin with. So that leads to lawsuits, but at least the patient doesn't need another angioplasty. And we found when we looked at intermediate lesions, these are 115 intermediate lesions, which I promise you, the bulk of them would have been sent to surgery. There were QCA around 40%, the vagaries of eyeball interpretation. The average plaque burden was 63%, and the MLA was less than 6 in only half of them. And the bulk of these patients, I promise you, without imaging, would have gone to surgery. Importantly, with the FFR IVUS controversy in left main, the left main correlation with MLAs below 5.9 and FFR actually pretty tight. That's because there's not that much variability in the left main length. So frankly, even though I use an awful lot of hemodynamic assessments of lesions, I think IVUS is better in the left main only in the sense that it gives you the anatomic information at the same time. And I'm satisfied that it gives you the functional assessment as well. And of course, IVUS is important. I'm not going to go into all the data, but here's some of the earliest data from Park showing that there does seem to be a consistent benefit long-term from using IVUS. And that's because, why? Because when you look at say the Excel, what happened when you use IVUS in left main, you use bigger balloons, you post-dilated, use higher pressures, you treat it stent under expansion. You just make it a much more durable result. And of course, we do have these older data from Park's group about the actual desire to have, say, in the Western world, 6, 7, 8, and 9 in the various limbs of the left main. But Akiko actually did another analysis of looking at the best outcomes in Excel. And as you can see here, our targets could be even bigger. And if you got to 11, you had a half the death MI stroke rate than you had when you were below 9. And and of course, it's even lower than even our traditional 9 group. So I think it's very important to really optimize and maximize it. Bigger is always better. Another aspect of it is you need to completely revascularize. And this just shows you residual syntax score and outcomes in the customized registry with left main. And if you leave a residual syntax score greater than 8, and this is very consistent in a lot of other analyses outside of left main, you do drive up the MACE rate. And this is sort of like, a CTO of the right, leaving a sizable territory behind. It's not, an OM or a diagonal or something like that. But the key message here is all, functionally important vessels of any reasonable size should be fixed. And of course, the functional syntax score actually trumps the anatomic. Now, lesion preparation is important. Remember, left main is a higher propensity for calcification, and I do think highly in specialty balloons in these situations with fibrosis and calcification, and also think of rotoblator and orbital atherectomy. The orbital isn't that suitable for the true aortoosteals, and of course we'll see where Shockwave sits in when it gets approved. But I think it's going to have some difficulty in utilization, only because keeping it inflated for prolonged periods in the left main can be difficult. But I think preparation is important. Very important, because you want to enhance stent delivery and expansion, and you want to avoid abrupt closure and dissections and the like. And I think that's very important. My philosophy with a left main, and frankly, certainly any calcified lesion, is I don't want any mystery when I put the stent in. I want the lesion prepared. I want to see full balloon expansion of non-compliant balloons before I put the stent in. And I think of the stent just sort of painting the vessel. The stent balloon is really doing no work. It's just expanding it against a prepared vessel. And I think that's particularly important in left main. This is just an example of, say, circumferential calcification in a distal left main. Some people could say, well, you should do atherectomy. Well, honestly, when you have this type of lumen, which is of course critical for left mains, but it's big enough that you can use Laplace's law to crack this calcium. And what here is where I would use, say, a specialty balloon, and then put in my stent. And here you have, I don't know why my little video isn't working, but here you see a nice 13 millimeter MLA, well beyond the 10. You want to use hemodynamic support. That's very controversial, but I think it's not every left main that needs support. We only use hemodynamic support 4% of the Excel trial. But when you're faced with individuals with left main, you've got, this is like, Passover, you got to ask the 4 questions. I ask one, is the patient hemodynamically unstable? Obviously, if they are, then, you want to use support. Secondly, does the patient have the reserve to sustain even a brief ischemic insult? This is true when you're in the last remaining vessel, but certainly in left mains, if you have borderline blood pressures, very low EFs. If they don't have it, if they can't tolerate even a brief insult or prolonged inflation, you should think of support. Is the patient at risk for a complete interruption? In other words, if you have thrombus, difficult wiring, the possibility of closing the vessel, if you think that could lead to hemodynamic support, that's where I do use support in that. And also, is the patient at risk for prolonged ischemic insult that may limit my ability to completely revascularize? And that's like if you're going to use long atheroblative runs or retrograde CTO with dual circulation compromise. If that's the case, then I will give support. And if not, but I'm in this situation, but thinking about it, I might get bilateral access and do a right heart cath really to monitor the patient. So I'm not going to get into this today, but also, lastly, I just want to talk about bifurcation stenting. Crossover is best, but don't have to bend over backwards. If you must, certainly with severe 111 lesions, you should not hesitate to use 2 stents. Safety first. And what you want to do, though, is remember, you want to size to the distal vessel. It's generally the LAD when you're crossing over. You need to pot proximal to the bifurcation. It's critical. And here is, the analysis of planned stenting versus planned 1 stent and 2 stent. But if you look at planned 2 stents with 2 side branches, and you look at the planned 2 stents with 0-1, there's no real disadvantage when you have that type of anatomy to using 2 stents. I think that's important. And in terms of, we could discuss this in a bit, what the preferences are. The fad, of course, is DK crush over culotte, and this is because of the DK crush 3. And this is sort of the long-term follow-up with less TBR, trend towards lower mortality, left myocardial infarction. And this relative benefit was in sort of simple bifurcations. That is a lesion length less than 10 and circ diameter stenosis less than 70%, or the more complex one, you did see a benefit. But that's one multi-center trial from a group of practice individuals, and we will have the data from the European Bifurcation Club left main, which is looked at 450 patients, looking at the crush versus the culotte. But importantly, if you're going to use 2 stents, IVUS is mandatory, and this just shows you the difference in 2 stent techniques, how much under expansion you get if you do not, before you actually IVUS it. And I'm not going to go into all the details of it. And also, in tenuous situations, even though we like to work distal to proximal, stabilize the left main first. If you have to, in very sick people, even use a V-stent. And I like also something called the bang bang, that I call it, which is using, say, a 7 or 8 French guide. You put 2 wires down the LAD and 1 in the circumflex. You have an NC balloon on 1 wire. You have a stent on the second. You put them both in the distal guide with 2 inflation devices. You dilate the preparation balloon, the NC balloon quickly, make sure there's full inflation, and then pull the balloon back and put the stent in. And then you can relax and IVUS, and once you've stabilized that tenuous situation. So I'm going to conclude here. I think in the majority of patients with left main disease, I think we have equipoise. We'll need further follow-up to reinforce or undermine the statement long-term, but I think in terms of cardiovascular mortality, we're heading to the point with our analyses now having 6-year median follow-up with cardiovascular mortality being equal. It's a question of the trade-off between late MI and the inconvenience of the cabbage. Many old assumptions need to be reevaluated, especially with diabetes and syntax score. And I think in fairness to your patients, and this is still not true in the many centers in the US, you need to be comfortable with left main intervention and know someone who is. So when they're in that anatomic group where it's an alternative, I think it's important that they're aware that there's an alternative to surgery. Thank you very much.
Thanks, Jeff. Wow, that was a marathon of data information. I think many of us will go over it again since it's recorded. But I think it was really important to put into context all the data, especially with the controversy that's happened, particularly on social media. It's amazing how a lot of this controversy has really been more on social media than in the journals, right? And then again, thanks to the technique. So I'm going to let Aisha come and get ready for the questions. I wanted to see if Eberhard had any comments before we started with the questions. You just need to unmute yourself, Eberhard.
Yeah, so Jeff, this was, as always, phenomenal. So I took some pictures here. The problem that you pointed out is really, when you look at these trials, as important as they were in order to open the door for left main stenting, which was a no-go many years ago when we started out. Left main you couldn't touch as an intervention cardiologist. All these trials were very important, but I think it is equally important to say now, after all these trials, your last point in your conclusions is extremely important, particularly if you look at the United States. All these trials are generalized patients and all operators. I'm just having a little bit of a problem comparing operators with operators, sites with sites. At the end of the day, it is your personal judgment, and you said that. I just wanted to reiterate that point. It is extremely important that you know how to do things. And that equally goes for circulatory support. If you don't know how to do left main stenting, risk of hemodynamic imbalance is higher than somebody that can do it quickly, fast, and straightforward. So all these things play into the judgment into individual patients, particularly when there might be an incentive for using circulatory support. As you know, in the US, circulatory support is way higher than in Europe, and there are reasons for it. Not only the reimbursement incentive, maybe also some kind of operator volumes. So thanks very much, Jeff. That was fantastic.
Thanks. As usual, Eberhard, you have very practical wisdom to impart.
Yeah, it is interesting, Eberhard and Jeff, how different, for me, having worked in Europe and now in the US, how different the indications for left main stenting are, right? We really adopted the syntax data and then the Excel data. And so for us, if in a patient with low syntax score or low to intermediate syntax score who was a good candidate for PCI, we allowed patients to choose that strategy. Right out. Okay, we gave them the option. You can have left main stenting, and so patient preference and choice was part of it. In the US, that's very different. I'm finding most of the left main stenting I'm doing are surgical turn down cases. So where the surgeon refuses to do it or says for whatever choice, it's different to do it. So it feeds really into one of the questions from the chat, which is, if we're all reading the same data, why are the guidelines so different in the US versus Europe? Any thoughts, Jeff?
Well, I'm not on the guideline committee, but let's just step back. I mentioned, remember, that you had the intermediate yellow in the European, and I know for a fact that was just done as a compromise with the surgeons. There was no data that justified that not being green. And that was the Europeans, where, as you know, I think the interventionalists hold much greater sway. In the US, the surgeons dominate, and the cardiovascular, the interventional representatives are, in general, not that forceful. There are some, but within the committees, the ones that are representing intervention aren't necessarily, say, as passionate about it or the data as we are. And for me, the frustration is the hard team interpretation is sort of now having the surgeons as our gatekeeper. But I think it's got to be flipped. We have to have an equal voice. I mean, how can you not offer a patient, say, how can a person go to a surgeon and get a TAVR without being offered, a SAVR and not being offered TAVR? Why can't patients who go to surgeons, why aren't they mandated to have a PCI review in appropriate situations? There's no penalty for just whisking off to surgery. And I think it's an imbalance that needs to be redressed in terms of fairness. We're looking at patient empowerment here.
Right. Aisha, I'll pass it on to you.
Yes, thank you, Dr. Latif, and thank you, Dr. Moses, for that brilliant talk. So my question is from a fellow's perspective of for someone starting out. You did mention that it shouldn't be a knee-jerk, all multivessel cases go for CABG. How much would you say should we factor in the syntax score in deciding on a strategy? And also in cases of angiographically intermediate stenosis, for all practical purposes, we can't both IVUS and FFR the same case when you consider finances and institutional practice, etc. How would you decide on which strategy to opt?
Yeah. It's like saying, which child do I want to keep? I mean, it's all right. First of all, I think it's important, two aspects of this. First of all, we do have a big review coming out on complete revascularization that Greg is the senior author on. And I think that's an important objective in neutralizing the benefits of CABG. When you look at syntax, just on the anatomic basis, if you look at the groups below residual syntax score of 8, there's no difference with surgery independent of the syntax score. The syntax score was a marker of the procedure you got. I look at what can I treat and can I deal with all the ischemic territories. That said, I think the anatomic basis of it is probably obsolete. I think, FFR or IFR based decision-making sort of trumps the anatomy. So I think it's important that you revascularize all critical ischemic territories. If you can't, then surgery is definitely the way to go, except in extraordinary circumstances of comorbidities and the like. But if you're talking about normal lifespan, et cetera, normal activity levels, I would go. So that to me is the key. Having to make a choice between, FFR, maybe, just maybe, when these angiographic techniques become more sophisticated and reliable, we won't need the actual invasive wire and we'll just do our analysis at the table side, or have it maybe from the CTA, and then we'll just go with imaging for implementation. But you cannot really use imaging outside of the left main to reliably determine the ischemic risk of the individuals. Having said that, though, we do know that there was one last year at TCT and it was published, an interesting trial comparing FFR with OCT, and you found that even though you had more resources and more PCI with OCT, you actually had, at least in the intermediate term, better outcomes. So I guess if you had to pick one, it would be IVUS, but I don't think that's a fair comparison. I don't think it's fair to do that to the patient.
That's a fair point. Thank you. There's another question on distal left main bifurcation as well as trifurcation, actually. What is your preferred planned two-stent strategy in case of left main bifurcation? And if you bail out, which technique? And along the same veins, also a question on trifurcating left main disease that has been refused by CABG.
All right, that's 3 questions. Let me see if I can remember all of them. But I think I even though it's work, I still prefer. I think the most versatile is the DK Crush. Culotte is great. We have a lot of fans of that, especially here in at Columbia and of course in Europe. But you need to be able to uniformly expand the stents properly in the left main, and large left mains that can be tricky if you don't have a stent that can both deal with a smaller vessel and expand to the proc. So I like the DK Crush. Bailout, I think TAP is great, especially in left main. If you're extruding a little bit into the left main, say bailing out on the circ, you still have a lot of room, right? Especially if you do, you have your final kiss. And as far as trifurcations go, I mean, I generally will, I'll try to keep that ramus, which is what we're talking about. I'll try to keep the ramus open if that's the smaller of the 3 branches. or the circ open, depending on that. But I will not, I think putting in 3 stents is frequently a bridge too far and can get you into real trouble.
So Jeff, along that line, the area where we see the most
Yeah.
restenosis. I mean, you've been doing this for a long time. I know Antonio has a very strong, ideas about what to do about left main.
That's the vulnerable area. That's why I like the double kiss in the DK crush, because it allows you to move the metal when you don't have, I want to, for lack of a better word, a junk heap in there with multiple overlying stents. You're just opening up one stent optimally. And then when you cross over and kiss again, you're really just opening up, just one stent again, one at a time. And I think that may be why you're dealing with, these favorable outcomes from the DK crush. Whether it's better than a well-done culotte, I will doubt that. But as I said, I like it because it's its versatility.
And maybe another question the fellows ask often for left main, your tips to nail the ostium of the left main. Okay,
all right. I use poor man's co-registration with IVUS. And when my IVUS is in any view, when my IVUS is at the ostium, I record it and try to match it to some fiduciary point, a rib, the spine. And that way, because otherwise you're sitting there puffing, your guide's disengaged, you don't know what you're doing anyway. A lot of people like the AP cranial. I really just like using the IVUS. I mean, use it anyway. And, from the data, if you miss 1 millimeter in either direction, it really has no impact. You just don't want it extruding too far. But having said that, I'm not a believer that you have to cover the ostium. If the ostium is pristine, I don't think you have to pull the stent back. I cover the plaque and leave the ostium alone because for re-engagement issues and the like, I think it's a safer technique.
Aisha?
Yes, thank you. There is another question actually. Besides intracoronary imaging, do you think any particular type of drug-eluting stent would make a difference in the long term? Newer discs related to strut thickness, radial force?
Obviously they're coming out with such stents, but the recent well-expanded stents, it's the lesion preparation, I think that's key. And if you understand what you're dealing with, fibrosis and calcium, especially with calcium, we're not debulking calcium. We're thinning it out enough so you can crack it and dissect it. And again, to quote Antonio, if you're not dissecting, you're not doing a good job. So it's really the expansion of the stent. And I haven't seen, a problem with, look at the Excel data, that's where they thin stretch stent. So I'm not sure the stent is keeping anything with a thicker strut more patent if you've actually prepared the lesion well enough. As I said, I'm just painting the stent onto the wall. I'm not having the stent really do much of the work except just keep the wall expanded like I did with my balloon or specialty balloon.
Jeff, I have a question, if I may, Azim. Looking at the imaging of left main, I totally agree with you. Just to play the devil's advocate, how important is FFR? Don't you think that FFR is overrated, to cite our friend Antonio?
Well, I like it.
Liking it is
I don't use it a lot in left mains, as I said. I think it can be anatomically driven there because of the strong correlations. But I do think IFR for tandem lesions and the like, intermediate lesions, I think it can really simplify a procedure without any sacrifice of outcomes. So yeah, I do. I mean, I'm not saying that we should be enslaved to it, but I do believe in, especially in multivessel disease, that it can be very helpful in guiding your therapy. Whether it's overrated or not, I'm not doing the rating, so I don't know. Is it 5 stars? Is it 4 star?
Aisha, how about one last question, maybe?
There's actually, I'd like to field 2 questions. One of them is related to the Excel subgroup analysis for the diabetic patient. Is there any reason why the non-CV death is higher in the PCI group over CABG? I mean, could higher bleeding risk or perhaps mortality due to DAPT? Yeah.
No, I mean, it was just, it was oddball pulmonary, it was infections, cancers. I remember there was, Eberhard will remember there was an imputation back in the day that DES caused more cancer. Remember that? Yeah, I know. It sounds silly, but this was actually a topic of actual discussion for a few months. No, I think it's play of chance. I think the key is that it's the, look, remember in syntax, diabetes doesn't fall out independent of the anatomy. It's the, remember, we're not doing super complex, diffuse, horrible diabetics that were in, say, Freedom. The Freedom patients, some of them were awful. You wouldn't ever consider doing a stent on them even today. So I think that's what the difference is between these with controllable, approachable anatomy versus things like Freedom, where, believe me, we were the core lab at CRF, and it was you were really shoehorning these patients into the trial.
And there's one more question from the chat. It's a PCI versus CABG question. In the real world, especially in the USA, there are many more surgeons who can perhaps proficiently perform a CABG than an IC who can do a left main PCI. So do you think real world outcomes would favor CABG? And has this poor patient selection got anything?
It's an important data set, I think, to analyze. But as I said in my last thing, if you don't know how to do it, know someone who does. It's like CTOs. You should have, if you don't have it in your center, you should have a resource. It's fair. I think it's only fair to the patient. CABG is, hard on the patient. They're not fun. I remember once a patient of mine, it was years ago, but he had a tight LAD. I said, come on, I can fix this. He was persuaded to have CABG. I remember I went up to see him afterwards. He says, you didn't tell me this was going to hurt so much. I said, yes, I did.
Jeff, there's another important question maybe. What are you doing for your left mains in DAPT? How long are you giving DAPT for?
A year.
1 stent, 2 stents? Any difference with 2 stents?
Complex anatomy, I think a year is across the board. I mean, and you know me, I love to minimize it. I like 3 months, but I think there's enough data. Remember, there was actually a nice data set that called out. Antonio was part of it. You were part of it. Where complex anatomy, it looked like a year was better. If they're not having high bleeding risk, I'll give it a year.
Yeah. Great. Jeff, thank you for giving us an hour of your time. That was just one of the more phenomenal talks we've had during this whole CATH conference. We've all learned so much, and you've given us the ability to keep it and share it with colleagues and relook at it. So thank you for that too. So it'll be on YouTube for whoever wants to look at it again and go over certain parts of it. We really appreciate it. Have a great day and see you hopefully in the next week.
Okay, I'll see you soon. Yeah. And Eberhard, wonderful to see you.
All right. Eberhard, thank you.
Thank you all for having me.
Thank you so much again.
Bye-bye.
Bye-bye.
Bye-bye.